Good evening again. And one of the most important topics in obstetrics, one of the dreadful situation an obstetrician can face in the lifetime, who one situation which nobody wants to face, in fact, is postpartum hemorrhage. For various reasons, as I go through the session, you would understand why everyone is scared of postpartum hemorrhage and really view it as a nightmarish experience or a bolt from the blue, right? So I would like to concentrate more on some of the predictors, how to really know whether my patient can have pph, and if at all I encounter, how am I going to manage the postpartum hemorrhage. So these are the aspects I would try to highlight in this next 1 hour. Are the slides moving? Can any one of you can say yes or no? So the moment we talk about um, postpartum hemorrhage, the thing that comes to our mind is Taj Mahal. We enjoy the view of Taj Mahal. We praise that that's a one of the wonders of the world. But you know why it was built? It was built because of uh, the memories of his wife. Shah Jahan has built it, and this is in memory of a faulty womb. She died of postpartum hemorrhage during her 14th delivery. So one of the important risk factor, I think all of you can remember, grand multiparity can be a very important risk factor for postpartum hemorrhage. If you just scan through the important causes of maternal mortality, you just come to know that hemorrhage constitutes about 27%. Rest of them, of course, sharing anywhere between 5 to 15%, whereas hemorrhage itself contributes almost one fourth to one third of the causes. The good news is the recent report has come out. Just a couple of weeks back, we received this report. Maternal mortality in India has dropped down to 97 from 130 in 2014 to 16. Now it is almost 97. This is a great news, and this is the SRS data that we have recently received. And this Millennium Development Goal aims at reducing the maternal mortality to 70 per lakh live births, and the achievers are Kerala, Maharashtra, Telangana. This is the order, and we have about 8 states that have already achieved it. Coming to the scenario on pph, developing countries, one third of the mmr I just mentioned, 27%, is because of pph, right? And pph is unpredictable in 60% of the cases. You cannot know that my patient can have pph. Just to quote an analogy, if you have a case of preeclampsia, you can anticipate that this patient can throw convulsions. So that is what is known as predictability. Whereas pph is not predictable in almost 60% of the cases, right? And the incidence is anywhere between 2 to 11%. Sometimes it is not recorded properly. So some of the estimates go to say that it could be almost 20%. That is, one in every 5 deliveries may end up with pph. pph doesn't always mean death. pph is something wherein the bleeding is beyond the prescribed limit. So of the 14 million cases per annum, case fatality is 1%. So just try to understand, we will save 99% of the pph patients. 1% probably will succumb to pph. 80% of the pph, postpartum hemorrhage, is atonic. So just to remind you once again, pph could be atonic when it is due to the decreased tonicity of the myometrium. Uterus fails to contract, or it could be traumatic. Traumatic is any time, anywhere, maybe a vaginal injury, cervical injury, uterine damage, anything that can cause bleeding is traumatic pph. Sometimes there could be a combination of both, right? And we have another term called severe pph, which occurs 1 in 1000 deliveries. So if you just remember, 1 in 5 could be PPH, but 1 in 1,000 will be severe PPH. So this is the most dreadful situation that we have. So now we go back to what exactly is postpartum hemorrhage. See, in vaginal delivery, if the patient loses more than 500 ml of blood after delivery, and in cesarean section, if she loses more than 1000 ml of blood, it is a kind of quantitative definition for postpartum hemorrhage. But clinically, many a times you may have an anemic patient, you may have an obese patient, you may have a lean patient with low blood volume. So finally, if you feel postpartum hemorrhage necessitates transfusion, this patient requires transfusion, then you can call it as a significant um, hemorrhage, postpartum hemorrhage. And if you have a pre-hemorrhage hemoglobin estimated, and if the fall is about 10%, earlier it was 10 grams and now it is 9 grams, probably that should be considered as PPH. See, anything that alters the pulse rate, BP, respiratory rate, urine output, etc., can also be labeled as um, postpartum hemorrhage. So, if I just want to summarize all these things, anything that significantly alters the vitals of the patient and necessitates transfusion probably can be called as PPH. So it could be minor when it is 500 to 1000 ml loss. Major is when the loss is more than 1 liter. And we used a term called severe PPH. Severe PPH is the term that we use for more than 2 liters of blood loss. 1 to 2 liters is called moderate blood loss, the moderate PPH. So when we talk about management, see, when it is always prevention is better than cure. So to prevent, you should know in whom you should act. So try to predict what are the situations, who are the patients in whom you can have PPH. So prediction of PPH, then comes the action that you take to prevent PPH. The third thing is you must be prepared. In spite of prediction and preventive measures, you may end up with cases having massive hemorrhages. So you should be well equipped. You must have been prepared to manage a PPH and finally proceed to manage the PPH. So prediction, prevention, preparations, and procedures. This is how I'm going to deal in this session. So causes of PPH have been classically taught as 4 T's: tone, tissue, trauma, thrombin. So tone is uterine atony. Trauma I just mentioned. Any genital tract injury can cause traumatic. Tissues. See, whenever the placenta retains or a part of the placenta retains, or you have got some abnormal placenta, for example, a succensuariate lobe, the main portion has come out, but the part of the placenta is still there, or significant amount of membranes get retained in the uterine cavity, the patient can continue to bleed. And finally, thrombin. Thrombin is DIC related bleeding. DIC related bleeding can occur due to various causes. I'm going to give a big list at the conclusion of this session. So, how to predict PPH? Prediction of PPH, lot of studies have been done and they have studied many factors that could be responsible for causing PPH. So in statistical terms, we use one value called odds ratio. If the odds ratio is more than 2 or close to 2, you can believe that that factor is a high risk factor. So antenatally, you have got risk factors like age more than 35 years, especially if you are doing a cesarean section. Asian ethnicity. Asians are more prone for PPH. This is just a evidence that has come out of various studies. Then if you look at other things, baby weight more than 4.5 kg. If that such babies deliver out, maybe cesarean or vaginal delivery, both of them increase the risk of PPH. Multiple pregnancy, presence of leiomyoma, that is fibroid uterus. Then you have got what is called the antepartum hemorrhage and also previous history of postpartum hemorrhage. If the patient in the previous pregnancy gives a history of PPH, it's very important. So when you are taking the obstetric history, you should be carefully asking about previous history of PPH, any blood transfusions made in the previous delivery. So that gives you a good idea, right? Coming to intrapartum risk factors, you see here prolonged third stage. When the third stage gets prolonged, as it gets prolonged, see, more than 30 minutes, the odds ratio becomes 6.2, right? And whenever you are doing an operative vaginal delivery and you try doing a vacuum delivery but it fails and you go for a forceps, this is called sequential instrument use. So that is a risk factor, and episiotomy is a risk factor. This is the reason now we discourage use of episiotomy universally. Only selected cases you are supposed to do. Presence of infection, oxytocin augmentation, emergency cesarean section. Compared to elective, emergency cesarean section has got uh, more chances of PPH. So if you look at the strongest predictors, previous PPH, emergency C-section, whenever you use oxytocin during delivery, those patients are more prone for PPH. General anesthesia usage, episiotomy, macrosomic baby delivery, and prolonged third stage are the most important and strongest predictors for PPH to occur during the present pregnancy. So, what are the preventive measures that you have to take? See, when the patient comes in pregnancy, you have to do this risk assessment. I just told you what are the situations in which she can have PPH. For example, she says, my first pregnancy I had PPH, or she say you find out that the weight of the baby seems to be more than 4.5 kg, you can anticipate. Or when you are dealing with a twin pregnancy, so I told you multiple pregnancy is a risk factor. So all these factors to be listed in her case sheet and assess the risk and prepare her. If you find that she is a high risk patient, you have to prepare her by anemia correction, energetic correction of anemia, and maintaining the HB preferably not at 11 grams, maybe at 12 grams, 13 grams, so that even if she bleeds, she should be able to sustain that loss. She should be able to tolerate this kind of loss, right? If there are any other health conditions, you have to improve and avoid emergency C-section. We have told you that emergency C-section causes more hemorrhage. So better take her up for elective C-section. And in case you have anticipated, don't try to deliver her at a PHC or a CHC. Shift her to centers with blood transfusion, intensive care unit, all the surgical facilities round the clock. So this is very important to measure that you have to take during antenatal period. Intranatal period, you have to be careful with induction. Don't induce every pregnancy that comes. Induction of labor increases the risk. Avoid prolonged labor. Good assessment and good decisions are the key to avoid prolonged labor. And whenever you are planning to use oxytocin, judiciously use it. For again, if some of the hospitals, when we enter, you find that every delivering woman has been put on oxytocin drip. It is not correct. It is not judicious. So you should judge properly and use oxytocin. So this is called injudicious use of oxytocin or uterotonics. And episiotomy should not be universal. Instrumental delivery, if at all planned, should be done by experts. The amateur postgraduates or those who are not having adequate training should avoid doing these things. And we keep talking about active management of third stage of labor. Please, students, remember this. This is a very, very important intervention during intranatal period to prevent the postpartum hemorrhage. It has been found, evidence has come out very strongly that AMTSL can reduce the chances of PPH by 60%, a big number. So AMTSL, which is 10 units of oxytocin given intramuscularly and followed by controlled cord traction if necessary, and uterine massaging was one of the components earlier. Now we are no longer recommending uterine massaging. It causes more of discomfort rather than decrease the chances of PPH. Then fourth stage monitoring is important. After the delivery of the placenta, you have to monitor the patient for at least 2 to 4 hours and then only shift her out into the ward. So what are the recommendations? 5 to 10 units of oxytocin given IM or IV is one of the preventive measure. Carbetocin, if available. Now we have heat stable carbetocin available. 100 micrograms intramuscular or intravenous can be given. The only problem with this is the cost of this compared to oxytocin. Methyl ergometrin 0.2 milligram IV or IM can be given if there are no contraindications, especially hypertension, cardiac disease, severe anemia, etc. You don't use this. Carboprost is not recommended by WHO for prevention. Kindly remember, earlier we used to tell you that PGF2 alpha is one more medication which can be used in the dose of 125 to 250 micrograms intramuscularly during the third stage. But for prevention, please underline this. Prevention is different, treatment is different. I am talking about prevention. For prevention, carboprost or PGF2 alpha is not recommended by WHO. It has been found that it causes more of loose motions and vomiting and not that beneficial compared to other medications. Misoprostol 400 to 600 micrograms oral or 1000 micrograms per rectal can be used as a second line if nothing else is available. If oxytocin is not available, then only you go for misoprostol. Otherwise, oxytocin is the first priority drug that should be used. And as I told you, uterine massaging is no longer recommended for prophylaxis. And now we are recommending tranexamic acid 0.5 to 1 gram in addition to oxytocin, especially during cesarean section to reduce blood loss in women at increased risk of PPH, right? And cord traction also is a controversial issue in vaginal delivery, but WHO clearly says during cesarean, cord traction helps to prevent the problem of PPH. So I have given a small information about the various drugs that are used: oxytocin, carbetocin, misoprostol, and PGF2 alpha, ergometrin, oxytocin plus ergometrin. We usually use a term called symptometrin, and misoprostol plus oxytocin. So of all these things, the maximally acting drug could be carbetocin, and it sustains its action for a longer time, so can be a good choice except for its cost. Oxytocin, time tested one and the first choice that we use, and it has a short duration of action compared to carbetocin. Misoprostol has the advantage of that it can be used by various routes, maybe oral, sublingual, perrectal, it can be used. In fact, misoprostol can be used vaginally, but in PPH or whenever the patient has delivered, you can't keep it in the vagina, so we don't use. Prostaglandins are not recommended for prevention of PPH. Ergometrin has its own limitations, like there are certain contraindications, so one should be careful. Now we finished prevention, prediction. Now what about the preparation? How do you prepare yourself? You have to be prepared with manpower, equipments, drugs that are used for PPH, blood bank facilities, and of course, ICU or high dependency units should be armored to take care of the patients. So these are called drills. So periodic drills, daily scrutiny of the drugs. Whenever you enter the labor room, you should be checking whether all the drugs are there, whether expiry date has not been crossed, whether they have been stored properly in the refrigerator, and whether the equipments are functioning. As simple as the oxygen cylinder, whether it is available, whether the oxygen in that is full, then do you have a spanner to open the cylinder wherever the central oxygen supply is not there, right? So the staff should be updated about the skills what they should follow when a bleeding woman comes. So it could be just like, you can create a situation, you can just shout that there is a patient with pph, and just observe how the situation is handled by the labor room staff, right? So this is called drill. And presence of hdu and icu availability is very important, and the blood bank officer should be requested to provide updates about the availability of blood and blood products daily, right? So these are the preparations that you make, because once you know the blood group, say let's suppose it is ab positive required, and your blood bank has about 5 units of ab positive, so you are sure. So if this patient bleeds, you are very sure my blood bank has 5 units, and you can quickly send someone to get those cross matched bloods, rather than sending them to some other blood bank and wasting time, right? And uninterrupted supply of group O negative blood is really essential, and it could be life saving. There should be an emergency bell in the labor room, because the doctor attending to these patients can need not run to the senior doctor and call them. The moment this bell is rung, everyone will become aware that some emergency is there in the hospital, right? And senior doctor coming and attending to the patient as quickly as possible will make a lot of difference because of the decision making. Students, I just want to mention you that the person who conducts delivery, it has been found that they always feel the bleeding is not much. They, even in spite of massive hemorrhage, they try to console themselves by thinking that, oh, this is not a huge hemorrhage. So they tend to neglect these things, and the patient might deteriorate. So involve some other person and take an indifferent opinion from a senior doctor, right? And having an anesthetist with you, having a physician with you, having a transfusion expert, that is multidisciplinary approach, is very essential and at this kind of situations. Clinical estimation of blood, if possible a quantitative estimation, if possible you can do it, otherwise don't bother about it. And you have a mnemonic for management of that is how to proceed. You have this mnemonic. What is your intention? You want to achieve hemostasis, you want to stop the bleeding, so the mnemonic itself is hemostasis. H, call for help. A, assess and resuscitate. E, try to find the etiology, use ecbolics and ensure the availability of blood. M, for massaging the uterus. See, now I just now said massage is not encouraged, but it is for prevention. But for treatment, you need to massage the uterus. O, for oxytocin and uh, prostaglandins. Yes, for shifting to the OT or to the higher center if you are working in a PHC. T, for tissue exclusion, trauma exclusion, and tamponade methods, right? And A, for application of compression sutures. S, for stepwise devascularization. I will get into the details shortly. I, for interventional radiology usage. And S, for subtotal hysterectomy, right? This is the mnemonic that we use for managing the um, postpartum hemorrhage, right? Students, this is not a stepwise approach. Please try to understand, some of the things should be done simultaneously, some of them can be bypassed. When you see that the patient, for example, a fifth gravida or sixth gravida having lot of hemorrhage after delivery, you can straight away decide about hysterectomy. So it is not that you have to go through each and every step and then go for hysterectomy. This decision has to be taken meticulously by one of the senior obstetricians. This is what I just want you people to understand. So coming to H, you need help from senior doctor, you need help from junior doctor, anesthetist, staff nurses, and group D. You may want to start a blood transfusion, you need a junior doctor for that. You may have to secure 2 or 3 IV lines. Anesthetist help is very useful here. Then you need to put a catheter, you need to take draw blood and send it to blood bank. You need the staff nurses for this. You need to get the oxygen cylinder, connect the oxygen, open the oxygen cylinder with a spanner. So all these things you need a group D. So don't underestimate or anybody. You need the help from everyone. Call help from every corner. So how to assess? Blood loss assessment, visual is not very reliable. So don't depend on that. So you look at two things: vital parameters, whether there is any tachycardia, hypotension, respiratory rate variation, tachypnea, etc. And there is a simple rule of 10. Rule of 10 states that if there is a fall in the systolic BP by 30 millimeter of mercury, let us say she had 120 systolic, if it becomes less than 90, that means fall below 30 millimeter. And if the pulse rate raises by 30, so she had a pulse rate of 90, now it is 130 or 140, which clearly says pulse rate has increased by 30 beats. And if the urine output is less than 30 ml per hour, and if the respiratory rate is more than 30 per minute, and if the hematocrit is less than 30%, then you can assume that your patient has lost more than 30% of the whole blood volume. So this is called rule of 30. But unfortunately, when the patient is bleeding, if you don't have an authentic earlier record, you will not know about fall of BP, rise of pulse rate or urine output. You have to wait for 1 hour to see whether it is 30 ml. And hematocrit estimation also routinely is not done in all the hospitals. So it may not be of much use. There you have another index called shock index, which is very simple and very useful, students. You look at her pulse and look at her systolic blood pressure. Pulse rate, let us say it is 80, and systolic blood pressure suppose 120. 80 by 120 is equal to point, I think it comes to 2 by 2 by 3. 2 by 3 will be 0.66 or zero point 0.7. So this is normal. As long as it is less than zero point 0.9, you are comfortable. Once it goes above 0 0.9, 1 or 1.1, you can find out that the patient is in shock. Simple example: pulse rate 100, systolic BP has fallen to 100. 100 by 100 becomes 1. So this is the shock index is 1. So you should be very careful here. Okay, so blood loss shows blood pressure change to various extent depending on how much of blood is lost. If 15 to 25% of the blood is lost, slight fall in BP, 25 to 35% marked fall in BP, and 35 to 45% profound fall. And the symptoms also: restlessness, pallor, urine problem, tachycardia, sweating, weakness. All these things will let us know that the PPH is severe. And in Africa, the home deliveries or institutional deliveries in lower hospitals, the midwives used a particular type of cloth called kanga. If there are more than 3 or 4 blood soaked kangas, then they would refer the woman immediately. So two kangas totally soaked will be 500 ml. So maximum they will wait for 3 or 4 kangas to be wet. Kanga is a type of a gauze roll which is used to estimate the blood supply. So you should have some rough estimate of blood supply. Just like your partogram, which had alert line and action line, this kind of alert and action lines have been created for PPH also. So if the clinical signs and symptoms are none, you get alerted. If you have got minimal changes in pulse rate, BP, and clinical signs have appeared, you start acting on these patients, right? So this is given by B. Lynch et al. Severity assessment, I just mentioned, you look at the vitals, you look at the need for blood transfusion. And initial assessment, you have to assess the etiology. Like, you feel the uterus. First thing you do is you put your hand on the abdomen and find out whether the uterus is tense, whether it is like a cork ball consistency, That is called a tonic uterus. If the uterus is not contracted, you can immediately make a diagnosis of atony. But don't stop at that. Try to examine the genital tract also to rule out any trauma. So, because there could be a combined hemorrhage, right? And try to find out from the history whether there are any precipitating factors for DIC, and examine the placenta properly, find out whether any cartilagen is missing or membranes are missing, right? In such cases, in every case, you send for CBC, coagulation screen, grouping and cross matching, and either reserve blood or arrange blood. So the general measures, you have to start IV fluids, start oxygen, catheterize, and if necessary, administer oxygen. Now coming to E, you have to evaluate, start ecbolics. Ecbolics are nothing but usually uterotonics, and confirm the etiology, ensure the availability of blood. So if the tone is at fault, you do massaging, you do bimanual compression, you use uterotonics. If tissue is the factor, like something remaining inside membranes or placenta, you have to remove the placenta, and you may have to curate the endometrial cavity, the decidua, for remnants of the placental tissue or membranes. If you are suspecting trauma, you have to repair cervical tears, you have to suture the episiotomy, you have to identify rupture uterus and act accordingly. And sometimes inversion of the uterus could be the cause for this, and you may have to correct the inversion. And if DIC is the factor, then you have to start using fresh frozen plasma, fibrinogen concentrates, etc., and try to correct these things, right? So uterotonics, these are the ones I have just mentioned about the details of these things, but here TGF2 alpha can be used as a uterotonic, right? Oxytocin, usually 5 to 10 units IM or IV is given, and about 40 units in 500 ml saline is started at the rate of 125 ml. Maximum dose that you can go is almost up to 100 units. Methyl ergometrin, if there are no contraindications, you can give 0.2 milligram IV, and after the first dose, if the bleeding doesn't stop, you can repeat it after 15 minutes again, and later on, the third, fourth, and fifth doses should be repeated at 2 to 4 hour interval. And maximum number of doses that you can use methyl ergometrin is 5 doses. PGF2 alpha carbopras, 250 microgram, it is given usually IM. And if for some reason you have opened the abdomen, maybe doing cesarean, you can give intramyometrial also. Once in every 15 minutes, you can go for a maximum of 8 doses, right? This is PGF2 alpha. Misoprostol is 600 to 1000 micrograms once the given. Tranexamic acid, you can continue using 8 hourly in the form of an IV drip you can give, or even slow IV can be given. WHO strongly recommend oxygen, and other things also it recommends, and the other professional organizations also endorse almost the same regimes as suggested by WHO. And oxytocin, it is better to avoid if there is hypersensitivity. Methyl ergometrin, avoid if there is hypertension or hypersensitivity. And side effects could be again severe hypertension, nausea, vomiting, and oxytocin can cause water intoxication. Carboplast is known to cause Carboprast is known to cause diarrhea, nausea, vomiting, bronchospasm occasionally. So one should be careful while using it in asthma cases, right? The other drugs used, I mentioned about tranexamic acid. So along with that, there is one more medication known as recombinant factor 7A, activated factor 7. It's a very expensive medication. One injection probably costing anywhere between 50 to 70,000 rupees. May not be an ideal thing for our Indian population, but some of the situations have shown a very promising action of recombinant factor 7A in certain cases of PPH. Carbetocin, especially the heat stable carbetocin, you have a study that has come out of using carbetocin called Champion study, where 30,000 women have been studied, even including Indian women, and this has been published in June 2018, and it is as safe and effective as oxytocin. Please underline the word for preventing postpartum hemorrhage. It is not used for treating postpartum hemorrhage. It is used for prevention of postpartum hemorrhage. Please, students, remember this, right? And I mentioned about general measures that have to be taken. You use a wide bore needle. Usually, you can use number 18 or number 16 needle, right? So if you say number 18 or 16 in emergency, your staff nurse may not be able to get it quickly. So you have to say number 18 or green needle, and gray needle or number 16. So these things will make her quickly get the required thing. You can even secure 2 IV lines to be on the safer side. And ideally, you should use either the best solution is normal saline, or else you can also use ringer lactate. Never use dextrose containing fluids, because they are hypotonic and they can make the patient further hypovolemic. And if you feel patient has lost 500 ml of blood, give about 2 liters of fluids, right? Best is replacing the blood, but till blood arrives, you have to hydrate her with the normotonic fluids like NS or ringer lactate. Monitor the urine output with catheter. The replacement also should be very meticulously done, otherwise patient can go for pulmonary edema. And colloids, which can increase the hydrostatic pressure significantly, can be considered till you get the blood, but not beyond 1.5 liters over 24 hours, right? And if you replace more than 80% of the volume only with fluids, then patient can go for again coagulopathy. That is called dilutional coagulopathy. So one should be cautious while using these things. Blood and blood products, you have to consider when the bleeding is continuing, loss is more than 30%, coagulopathy is there, and there is a role of cell salvage and auto transfusion. Right now, the facilities are not available everywhere, but you can use the same blood, run it through the machine, salvage machine, and you can use the same blood for transfusing back to the patient. So that is right now not available with us. The choice of blood could be O group Rh negative in dire emergency. Otherwise, grouped and cross-matched packed cells only should be used. If you are using 6 units of packed cells, give 4 to 6 units of FFP. It is given in the ratio of 1:1:1. That is 1 unit of packed cell, 1 unit of FFP, and 1 unit of platelet. This is called MTP, Massive Transfusion Protocol. So the fibrinogen content, if less than 100, ideal blood product could be cryoprecipitate, right? And blood transfusion better early than late. If you delay it, by the time patient can go for DIC. Never use old blood that is there in the fridge for someone else. Don't use it. Never use cold blood, right? Cold blood in the sense directly from the fridge, because massive transfusion protocol, you better warm the blood and use it. But if you are using 1 or 2 units of blood, you can definitely you need not warm. You can run it slowly so that by the time it reaches the patient through the tube, it gets warmed up. Don't use sold blood, sold to someone else. That should not be used for the patient. Always check the transfusion bag. Use a blood transfusion set. Don't use drip set. And also check the transfusion bag. What I mean by checking is the IP number, name of the patient, blood group and RH, and cross matching information. All these things should be checked. Otherwise, blood transfusion itself can sometimes cause grave reactions and we may lose the patient. M and O, massage and medical methods continued. Massage of the uterus should be continued, and medical methods, oxytocin or whatever you are using, should be continued. O for shifting the patient to operation theater or oxytocin usage, in either of the two. So shift the patient to the OT. If it is from a lower center, you can shift the patient to a higher center. right? While shifting, one should be careful to shift the patient in using non-pneumatic anti-shock garment. This is present with most of the hospitals now, and you can see the anti-shock garment on the left side, and on the right side you can see the same thing being applied. You see, this causes good compression of the lower half of the body, so reduces the perfusion pressure in the lower half. At the same time, the blood gets redistributed to the upper half, that is the vital organs. So this can sustain the woman for 3 to 5 hours. So by the time she shifted elsewhere, she tries to come up and tries to continue to have good perfusion pressure, right? T is for tamponade. And what are the tamponade methods? Uterine massaging, bimanual compression, using the right hand fist and the left hand on the abdomen, right hand fist placed in front in the anterior fornix through the vagina, and the left hand placed behind the uterus through the abdomen, and compressing these two hands is called bimanual compression. It should be continuously done for 5 to 10 minutes. Then there are people who have tried putting a thick pack inside the uterus with lot of pressure. You can also use uterine tamponade using Foley's catheter balloon. You put the Foley's catheter inside the uterine cavity and inflate the balloon. You may have to use 2 or 3 Foley's catheter, even more. Bakri balloon is a very ideal kind of tamponade that you can use because it fits snugly onto the walls of the uterus, and it causes a good pressure to reduce bleeding. If nothing is available, the routine condoms can be used, to which you can attach an infant feeding tube and then tie the neck and introduce the condom into the uterine cavity and start filling it up to 200 to 300 ml of warm saline. This is going to cause a good pressure inside the uterine cavity and also causes hemostasis, right? And as temporary measure, someone can compress the aorta through the abdomen with their fist. A good compression on the aorta can reduce the perfusion pressure in the pelvis, and this reduces the flow rate and thus encourages clotting. And the next conservative procedure would be compression sutures. So I'll come to that little later, right? What is the physiological basis of all these things? Whether you do devascularization, bimanual compression, balloon tamponade, or uterine artery embolization, all these things, what exactly happens is the vessels get occluded. By these things, when you are pressing, the vessels get occluded and this slows down the circulation. When the circulation slows down, the pressure in the uterine arteries will come down, and if the patient has adequate platelets and fibrinogen, clotting is initiated. Slowing down circulation will initiate clotting, but for clotting you require platelets and fibrinogen. If those two are adequately present, then immediately clotting occurs. Once clotting occurs, further bleeding is prevented. So this is the physiological basis of action of all these things. So the first one, the picture that you are seeing left upper top, is the Bakri balloon. Same Bakri balloon applied inside the uterus, how it fits into the uterine cavity. And right corner, upper corner, is the bimanual compression I just now explained. And lower you have, on the left side you have got Sengstaken black Murray tube, and on the right side you have Foley's balloon, inflating the Foley's balloon. These are the various tamponade gadgets that you can use to cause hemostasis. This is how you pack the uterus. We have a special uterine packing forceps, not universally practiced, but it can be considered in case you don't have facility for anything. Then application of compression sutures. Again, compression sutures also act by causing decreased in the perfusion pressure and clotting, right? You have got varieties of stitches: B-Lynch, Heyman, Cho, Global Stitch, Pereira Stitch, Oahba stitch, Hacketal stitch, Matsubarayano, Nasica is the latest addition. Cervicoischemic is one which is used for the lower segment bleeding, right? So this is the B-Lynch stitch. B-Lynch stitch is, I have just shown you, it is like a braces stitch which is used to encircle from below upwards and going through the cavity and approximates the anterior wall with the posterior wall. So this causes so much of compression that the uterus, the endometrial surface becomes approximated anterior and posterior, and they stop bleeding. Every stitch aims at the same thing, right? This is Heyman stitch. Unlike your B-Lynch stitch, which I showed you, B-Lynch stitch is a continuous stitch. I start at point 1 and come out at point 6 with a single thread. Whereas in Heyman stitch, I have two different stitches, one on the right side, one on the left side. So that is the difference between these two. Then you have got Pereira stitch, in which you are going to encircle circular stitches around the body of the uterus and also two vertical stitches. Oahba stitch uses two transverse stitches above and below the incision of the uterus, and again two oblique stitches at the cornual end to approximate the upper segment anterior and posterior surface. And you have got Hackathal stitch. You can just look at the way they have been applied. And Makino Takeda. Students, you need not remember everything. If you remember B. Lynch, you remember Heyman, that should be more than enough. The rest of the things only for information. I am telling you, rest of the things are not important. Everyone need not practice or know everything. If you know one or two methods which may be useful, that is more than enough, right? So this is called Matsubara Yano. Matsubara Yano and Cho stitch are very similar, and you have got Marasinge stitch, in which you are going to take a bite through the fundus of the uterus also in Heyman's, right? So Medanli stitch, a large single square stitch for the whole of the uterus. Same Cho stitch. Cho stitch is small squares that you put about 4 or 5 on the uterus, whereas Medanli stitch is a single stitch which encompasses the whole of the uterus. This is right lower is called global stitch by Gunashila, right? This is the cervicoischemic stitch. When the patient of placenta previa starts bleeding, you are going to apply stitches just below the incision of the lower segment, two stitches on either side to approximate the anterior and posterior wall of the uterus. It is supposed to be quite good. We practice it routinely. So these are some of the pictures, and right upper corner you are seeing Cho stitch, right? Small square Cho stitch. So these are my personal pictures. So I'm confidently telling what is what. Many of them, right? This is the latest addition called Nasika stitch, right? Nasika stitch has been considered very useful, especially in placenta accreta and placenta increta spectrum, wherein you are going to apply multiple transverse stitches along the midline of the uterus, both anteriorly and posteriorly if required. And this is called Nasika because this is an imaginary, a fictitious huge worm. You can see the figure D. That is how the worm has been imagined to be. It's a fictitious worm in the Japan literature. So this stitch is called Nasika stitch. And then coming to the stepwise devascularization. You know, this is a small model of the uterus in which we have tried to show the location of blocking the vessels. You see, you have the incision here. This is the incision that has been made for the lower segment cesarean section. So almost little lateral to that, you have the ligation of the uterines. Go little low down, you can ligate the descending branch of the uterine. And if you come to the cornual end, at the cornual end, you are going to ligate for the utero-ovarian anastomosis. So what exactly is stepwise devascularization? It is one after the other. You are going to block the circulation to the uterus so that the pressure inside the uterus slowly comes down and the clotting is encouraged and the bleeding comes down. So we usually start with one side uterine vessel. If it doesn't work, we go to the uterine vessel on the other side. Then we go to utero-ovarian anastomosis on one side, go to the utero-ovarian anastomosis on the other side, and then if all these things do not work, we go for ligating the anterior division of the internal iliac artery, which is the source for uterine vessel. So there is extensive anastomotic channels which get developed later, so uterus doesn't undergo necrosis or anything when you ligate these things. This is the advantage of using stepwise devascularization. So you can just see again the same picture. So this is the uterine vessel, descending vessel, ascending vessel. So descending vessel occasionally have to be ligated, and this is the ligation of the utero ovarian anastomosis, right? So in this picture, I have shown how you can see the uterine vessel on one of the broad ligament. When we have opened the two layers of the broad ligament, you are so nicely seeing the uterine vessel running on the lateral wall of the uterus. There is no need to expose it and then ligate. In this case, we were able to do it. So I have just shown it here. Then comes the importance of interventional radiology. Interventional radiology we make use to block the vessels supplying the uterus, that is internal iliac artery embolization or uterine artery embolization. This is going to help in stopping the blood flow. So here what we do, you should be having the facility for this. This doesn't require laparotomy. This is the advantage. So for vaginal delivery PPH, you can try this first if it is available in your hospital. So they put a catheter through the femoral vessel, go to the internal iliac artery, and then block the internal iliac artery either using polyvinyl alcohol or gel foam pieces, right? So this also after 4 to 6 weeks it gets recanalized. So this is the picture showing on the left side. You are seeing so much of bleeding at the center. After embolization, the bleeding has ceased. This is how you can show it. So comparatively, you can see that success rate is almost 85 to 90% with most of the methods. So I mentioned about recombinant factor sub Na. Then one of the answer for the final answer would be using hysterectomy. So subtotal hysterectomy is usually practiced because the bleeding atony is usually from the upper segment and you have to quickly finish the surgery to save the patient. But if the bleeding is because of placenta previa, you may have to do total hysterectomy, right? Other rare causes, this is one cause in which uterus is inverted. You can see the fundus coming out. This also can cause so much of bleeding. You can reduce, you have to immediately reduce it and then start oxytocin. Rarely you may have to do hysterectomy, right? Traumatic PPH can occur because of episiotomy, perineal tears, any kind of tear, vault rupture, uterine rupture. And what we do, you explore under anesthesia, suture it. You may have to do hysterectomy if the rupture is too bad. You can try with packing. You can use tranexamic acid, or this is one situation wherein you can use the you can use uterine artery embolization, right? So this is one of the bad rupture of the uterus on the lateral wall that you are seeing. Then see, this is a small, it looks like a small hematoma at the perineal region. See, you can see in the vagina you are seeing a huge clot, right? And when we explored, it started bleeding continuously. And you know, on the right side, what you are seeing is the same patient in whom the bleeding has extended into the abdominal cavity. What you are seeing there is the mesentery, blood clot in the mesentery, which has ascended up from the perineum, right? So this is the blood clot that you are seeing in the retroperitoneal region. So blood had seeped up to the level of the liver behind the peritoneum from the perineum. So it could be so massive and it could be life threatening. This patient survived after we ligated the vessels. Coming to tissue factor, you have retained placenta, retained bits of placenta or membranes. You have to do manual removal of the same. And I said I'll give you a list of the causes of BIC. Any bleeding, massive bleeding, atony or traumatic can end up with BIC. Otherwise, APH, intrauterine fetal demise, amniotic fluid embolism, severe sepsis, severe preeclampsia, or the other causes of BIC. You have to replace the factors, monitor carefully. This is one situation. You can use recombinant factor 7A provided platelet and fibrogen are replaced properly, and but guarded decision for surgical intervention. She can bleed during surgery, and intensive care unit is a rule. The last point is about secondary PPH, infection, retained bits of placenta. Maybe the secondary hemorrhage can be life threatening, can be associated with BIC. You have to use antibiotics, stabilize the patient, and packing if necessary. Surgery is usually rarely indicated, but always keep in mind whether there is any foreign body which is the cause for secondary PPH. So final message is intervene in the golden hour. You have to take a decision depending on what is the pathology. Teamwork is very important and experience counts a lot in success. Then assess and treat. That is proper diagnosis. If you miss rupture, if you miss a tear and treat only atony, patient continues to bleed. Availability of the blood makes a lot of difference. And finally, I would say you should have a judicious decision about where to treat this patient, whether your hospital is equipped or she has to be referred. So with this, we will conclude this session. Thank you.